Welcome back, everyone. It's great to have you here again. We're going to talk about managing operations in a shifting operational landscape. It is my pleasure and privilege to welcome Jonathan here today, and Jonathan Westall here today. Jonathan is Vice President of Ancillary Services at MLK Hospital in Los Angeles. First of all, Jonathan, welcome.
Thank you. Pleasure to be here. Thank you for having me.
Absolutely. So let's begin. Tell us a little bit about yourself briefly and about MLK Hospital. It's somewhat unusual in certain respects, and I'd like to have you be able to fill that out for our audience.
Not a problem. So as was stated, my name is Jonathan Westall. I'm the Vice President of Ancillary Service at Martin Luther King. I oversee all our service lines and non-clinical supports as well. Prior to that, I worked at Huntington Hospital in Pasadena, California as the Director of Support Services, similar role. That was kind of my first foray into healthcare. Before that, I did corporate security for Sony's PlayStation division. And then before that, I worked in various state, federal, private correctional facilities across the US, which all, no one really thinks of this, have a joint commission accredited hospital with inside them, as inmates have medical problems just like the rest of the population. So that was kind of my first touch in healthcare. As you stated, MLK is a little bit unique. It's a public-private partnership. We are a standalone nonprofit, but the building was built by the County of Los Angeles, and we rent that building. Very similar to a tenant-landlord apartment relationship. We pay a check every month. MLK is in the Compton Watts section of South Los Angeles, traditionally one of the most underserved communities in the US when it comes to healthcare. It's considered a medical desert. You drive around the areas, you don't see your CVS Minute clinics, your primary care physicians' offices, your urgent cares, those things you would find in more affluent communities where you have either cash paying customers or the commercially insured. Most of our patient population is uninsured or Medicare or Medi-Cal. So it's a tough payer mix. We have a kind of specific funding agreement from the state, it's actually a state law of how MLK is reimbursed, or else we would not be a viable from a business standpoint. So we are 131 beds. We do most of our volume through the ED on the grand scheme of things. That's a small hospital. We are the busiest emergency department in Los Angeles. On a 28-bed ED, we see 110, 120,000 patients a year. It's quite a few. We have been in, we call them alternative treatment spaces for years before COVID. COVID started and everybody moved towards like a tent or a respiratory area outside. For us, that was old hat. We've been doing that for years before COVID. So some of the strategies MLK implemented became a model for some organizations that normally wouldn't turn to us for advice. Some of the more affluent organizations who had never been in a predicament where they had to treat patients outside in a tent or they had to treat patients in waiting rooms. So it became kind of a hub for coming down for some lessons learned that we unfortunately had learned years prior to COVID.
Right. And one of the things, obviously, you and your colleagues know that you have to do everything on a budget, that, no frills, very carefully thought out plans. Tell me a little bit more. I love what you said about, you had already been doing some things that other hospital-based organizations had to turn to during the pandemic, have had to turn to. What were some of the things that you already knew that other hospitals have turned to you for in terms of really making the most with the fewest resources, in terms of agility? I think one of the things that's most interesting to me about your story is the story of the organization's agility, that you have to be constantly agile in everything you do. And so when everyone in the country, really everyone in the world, was faced with shortages of PPE, for example, and had to think very quickly and in an agile way about staffing beds and shifting beds from one use to another. You folks had already been doing that. So what were some of the things that you were able to share with your colleagues at other hospital-based organizations?
So personally, I hate buzzwords and I hate like the catchphrases. I'm going to use one right now that I despise, but thinking outside the box. Everybody says that, right? But healthcare organizations have traditionally purchased everything through GPOs, group purchasing organizations. They're on an allocation that they get X amount of gloves, X amount of masks every month. The supply chain couldn't handle that when the hospitals were overrun with a volume of patients who had especially respiratory issues, COVID-related symptoms that they needed this equipment for. So our team, luckily MLK is only 6 years old. So we have a relatively young team. Like I said, I've been there 4 years and I feel like I'm kind of one of the old guard there, which is a weird thing to say, but we have a lot of folks who are not healthcare based in their career, myself included. I started in security and moved that way. So it was looking to other industries that we had seen do this well. And I'm not knocking anybody who's made a career in healthcare or saying that when you got your master's in healthcare and you did your administrative fellowship and progressed up the ranks that way, there is a place in healthcare for those folks, 100%. We need those. We have some of those folks with us. But I also think sometimes healthcare overlooks the person who doesn't have the healthcare background. You can find a great operations individual who doesn't come from healthcare. My CEO will frown on this, I'm sure, but running a prison from the management side is very similar to running a hospital. You're caring for individuals. Folks who go to prison are not there for punishment. That is their punishment. So you have to take care of their basic life needs, as well as you have to do that with your patients too. Obviously, you go above and beyond for your patient population. But we started looking like at non-traditional vendors. We had folks who sat in a war room, essentially we called it, and were on the phone with vendors in China and overseas, and how quick could we get stuff here. Looking at nail salons. Luckily, we're in Los Angeles, so it's a huge area, but calling your local nail salons, tattoo shops. These places have stockpiles of gloves, disinfectant wipes, masks, all the things we were looking for, and due to COVID regulations, they couldn't open. Most of these places were more than happy to donate. And if not donate, we were more than happy to purchase some of these supplies. And sometimes it's going out and sending a driver out to pick up 20 boxes of gloves. That doesn't seem like a lot, but when you do that 30, 40, 50 times, now you're set on gloves for the week. So it was looking at those places we hadn't normally looked.
Yeah, exactly. And you mentioned the term war room. You've also said to me command center. One of the things that's interesting to me is because the entire country, the entire world was plunged into a crisis last spring. Healthcare, one of the things that CEOs have told me and other senior leaders in hospitals, medical groups, and health systems have told me is they learned that they could move fast when they needed to because of the pandemic. Everyone went to as much telehealth as possible quickly. So one of the things that's been shared with me and my team by senior leaders in patient care organizations is there is some agility, latent and potential agility there. Historically, healthcare thinking has been slow. And I don't mean that. That sounds really bad. Just advocating slow.
It's
know what
an
I mean?
Institution. It's similar to like the banking institution.
Right.
These ingrained institutions that have been around for hundreds of years. There's a certain way of doing it that has always worked. And I'm not saying it's worked to the best ability within the country, but it's worked. So there hasn't been an impetus for change where, like you said, telehealth is a perfect example. The pandemic pushed telehealth ahead probably 50 years. All of a sudden you can get reimbursed for it. All of a sudden people are adapting to it. People were scared to go to the emergency room. Our volume went from 400 a day to 25 a day. Our inpatient volume went 500% through the roof, but the people weren't coming for the ED for basic medical care anymore. They were embracing that, hey, I have a cold. I just know I need a basic antibiotic. I can jump on telehealth. I can see the doc right there. I mean, listen, telehealth's never going to be appropriate for narcotics and for major health issues, but come sit in the ED for 4 or 5 hours just to get amoxicillin or a basic antibiotic, or get on the app, talk with the doc, and then you can go to CVS or Walgreens or wherever your pharmacy is and pick it up right away. So you're right. I think the idea that we have self-imposed or governmentally imposed a lot of regulations and red tape, when we were forced to adjust and cut through that, it happened pretty quickly. So I think there are some lessons learned, and I hope that the the government regulation as well as kind of healthcare self-imposed regulation doesn't take steps backwards on this. I mean, there's guidelines in place for a reason. We all need guidelines and boundaries, but some of this stuff we realize that it's a little outdated and we could adjust quicker. The name of the game is to keep folks out of the hospital. I would hope someday that I'm out of a job. That's not realistic, but the idea that we don't need healthcare would be amazing. You know what I mean? People don't get sick. We don't have these issues. So many of these issues are we cause them ourselves. Our poor diet, poor eating habits. Like I said, people still smoke cigarettes, excessive alcohol use, stuff like that. And those people, or not those people, I shouldn't say, but people who embraced that negative lifestyle, all of a sudden they didn't have the outlet to just go to the hospital anymore. So I'm hoping some of that stuff changes, and we keep moving forward in a direction where people don't ever need to come for an inpatient stay.
Yeah, absolutely. Let me drill down in two areas: ED and inpatient beds, especially ICU. As you mentioned, the vast bulk of what you and your colleagues manage is ED, is emergency care of some kind. You obviously have some inpatient beds, and what many people told me and my team was what they've told us during the pandemic is they've had to think in such flexible ways. One day, you need more beds of this type and another day of that type. And they've had to think about, the crisis of nurse staffing, right? All these things. What kinds of experiences have you had around staffing people and staffing beds, and that the agility around being constantly flexible and able to shift things around?
So I'll take the beds approach first in the space. I think we realized really quickly that any area can be anything if you put your mind to it. A med-surg tele floor, when you don't have med-surg tele patients, is now your ICU floor. Don't get me wrong, it took our engineers a little bit to figure out oxygen for all those beds and reroute some electrical and stuff. But our team working day and night to get that done was key. Looking at, we had a gift shop. We traditionally, maybe did like $800 a month in sales in the gift shop. At that point, keeping it open was not top of mind. We turned our gift shop into a low acuity treatment. People need stitches, something very simple. So we're treating patients in the gift shop. They said taking certain alcoves and calling them discharge lounges, things like that. Just being flexible with the space and things that you would have thought were crazy 3 years ago or 3 months ago or something like that. It's not. When everything's on the table, you make it work. And then the second piece is staffing. You're right. I think it was eye-opening across the country. We have a shortage of medical personnel. Also, too, I think we realized that there's alternative or higher level providers. You don't need a physician for everything. You don't need a registered nurse for everything. There are certain things based on their license they do need to do, and I'm not ever going to argue that. But some of the smaller tasks can be farmed down. You know what I mean? We had people pitching in for everything. We have a valet staff basically because of a parking crunch at the hospital, not really a concierge service, more of a we need to double park the cars. It's Los Angeles. That's a normal thing. But our
very LA.
Exactly right. Our valets can pass out trays just as well as they park cars. So if a patient is clear, not on any sort of restricted diet, the idea that we need a registered nurse to bring that tray of food in, take that off their plate. In California, we have nursing ratios. Knock on wood, thank God we never were out of ratio. But you're right, it was also finding staff. You have the traditional traveler agencies, but our HR team did a great job of beating down the path of, the LinkedIn, the Indeeds, that you have to cover a large swath of recruitment areas to get people onboarded quick. Yeah, and then you look at like my generation uses LinkedIn for everything. The generation a little bit before me uses like a Monster or Indeed. A generation before that used newspaper. So you need to cater your message to this multi-generational workforce when you're trying to find certain specialties. When you just post on LinkedIn, you miss a huge group of people who don't look at LinkedIn but are still looking for a job. You just post in a newspaper, same thing. You have to hit it from all angles. So I think having like our HR team is great because they have someone from every generation on that team. Having someone who knows what their peer group looks at or what they're looking for is ideal. That's where you're hitting every market, every outlet.
Where do you think, yes, where do you think some organizations, of course, we won't name any names, might be falling down a little bit more while other organizations are fully on the agility train, right?
Yeah, I think I mean, everybody wants zero turnover. I think zero turnover is negative. I think workforce gets stagnant. I think you constantly need to be bringing in new people. And that's, again, a different way of thinking than my father stayed at the same job for 40 years. You know what I mean? And to me, I've been at this job 4 years, and it's the longest one I've ever had. Now, should you be jumping ship every year, 18 months? No. But 4, 5, 6, 7 years at a place, you know what I mean? At that point, like, you have made your mark and you've done what you were set out to do. And it's time to get other eyes on things. So I think that's where some organizations kind of fall down, is they have so much legacy talent that talent would be super effective at a sister organization who hasn't had that set of eyes on it, but maybe someone up and coming or someone new would be great to put a new set of eyes on. I think a constant flow of new talent as well as legacy knowledge is key for an organization's growth.
That's interesting. When you look at data and the use of data in situations like this, can you speak to that also? Many in our audience are healthcare IT people. They're trying to help the clinician and administrative leaders become more flexible, become more agile, and they're trying to do the right thing by using data in the right way and using it as smartly as possible, intelligently as possible. Do you have any thoughts about that?
So two pieces to that. I think one, IT is healthcare's biggest opportunity. I worked for an IT company. I worked for Sony PlayStation. They make video games. You know, I mean, I was on the operations side, but I saw what amazing coders can do. I saw what the things people can get behind a computer and do is, I mean, it blows my mind. And I think healthcare falls down on that because, one, we take an old school approach of no remote work, everybody on site, business hours. The people with the computer degrees that are coming out of school right now and the things they can do, they're looking for job flexibility. They're looking to be, you know, I mean, the best talent might be in Idaho and I'm in Los Angeles. Well, great, let them work from home in Idaho and handle this for us. So I think one, healthcare needs to jump on that train where, you know what I mean, to retain and attract the best IT talent, you have to offer flexible work. You have to. And then when we talk about like data and analytics, I think the EMR that we've all adopted. I mean, I think everybody's what Meditech, Cerner, or Epic is pretty much the big three, but it's become too much. You know what I mean? A physician comes in or a nurse comes in, they spend the whole time in front of a computer clicking boxes instead of talking to the patient. I get the idea of an EMR. I think we might have gone a little too far in one direction with it. But the data gleaned from it's helped. When we went to ask that, we had a bunch of National Guard nurses, physicians and assistants come in from the state because we were overrun. No one heard that until we presented the data. When we said we're a 131 bed hospital with 300 inpatients and 295 of them have COVID, that means my census is 100% COVID, where our hospitals around us were not. So getting that data and getting it in decision makers is key. And it helps drive decisions. It also, I mean, take something like I said, the gift shop earlier. I mean, I knew the gift shop didn't make much money, but when I looked at what the square footage of the gift shop was, it's a small area, but the price per square footage, essentially I was losing when I talk about a strictly financial standpoint from the patient revenue I could have gained from that. It was a no-brainer. Close the gift shop, move all the stuff into storage, and get the patients in there. Never mind, from a standpoint, it's much better to treat a patient inside than outside, no matter what the situation is. But the data helps us justify that. There's always the good idea for the patient experience, patient's comfort, on board with that. But there has to be some business case for it, whether that's a financial business case, whether that's an acuity business case from a healthcare standpoint. But you have to have the numbers and the data to back up what your opinion is. I think that's key.
Yeah, absolutely. And one of the things I think that swirls around all of this is, going forward, all healthcare consumers are starting to become more empowered now. and certainly more aware. I would say consumer awareness is growing. You know, we all are consumers in multiple ways. We shop for food, we bank, we shop online or in person for clothing and household goods. And one of the things that was so interesting, has been so interesting in this pandemic is, you know, when everything was shut down early last spring 2020, almost everyone was shopping wildly online, right, for basics, because so many things were actually shut down. And many Americans became very used to really good service, right?
On-demand.
On-demand service, very prompt,
Mhm.
you know, ordering online from whoever, we won't name names, and you know, you get your new tweed jacket in 3 days, right? And it's what you were looking for, and you know, you paid quickly and easily. It just, you know, you did it in 3 clicks.
Mhm.
Healthcare has never been like that, and we're trying
No.
to make it more like that. I think that that will also play a role here. And at the same time, all of the people who work in your hospital and every hospital are also consumers, right?
Correct.
Where every one of us is a consumer. All people who work in hospitals, medical groups, and health systems are consumers. So they also have had, you know, like if you're going to staff with agency nurses, which has become really problematic during the pandemic.
Expensive.
Yeah, very expensive and very difficult, even if you have the money.
Mhm.
But there are people who have chosen that kind of work style because they want that flexibility, right?
Correct.
So they're also a consumer of a sort. And so if you're interacting with them as potential contract staff, you have to know how to treat them. You have to know how to give them a good online experience, and certainly you need to give your patients a good online experience, and your core clinician staff and others. So how does that to you speak to the ways in which we're going to need to leverage technology and really think, I will avoid saying think outside the box.
Yeah.
Think,
Already covered the buzzword.
right. Think proactively and in a contemporary way, because you're not 100 years old.
No.
You know,
I think there's 2 parts to that. One, you hit the consumerism right on the head, that people go to Facebook and Yelp and get a review there before they go to Leapfrog or CMS, which is, from a healthcare standpoint, to me, that's crazy. Why wouldn't you want to go to like Leapfrog and see a patient safety grade rather than Yelp to hear the person complain that the noodles were cold? You know what I mean? But that's the society we live in. So I think, one, you have to have somebody or some entity in your organization that is super focused on your reviews and things like that, where people are leaving comments, where they're discussing your hospital. And sometimes that's a totally non-healthcare related person, that they're a social media expert or an online marketer. I think the second piece is we have to move more into like the telemedicine and the online or the digital on-demand things. Listen, if healthcare was appropriate or patient-centered, like we all claim it is, then our physician would be open from 5 p.m. to midnight. My wife just had a baby 2 weeks ago. And
oh, congratulations.
Thank you. Yeah. Our doctor's appointments were only available on Monday from 10 to 4 or Tuesday from 9 to noon. Well, I have a full-time job, which I need to provide the insurance for said doctor's appointments, but they're only open during times that I work. So if healthcare was patient-centric, it would be open second shift for the rest of us, and we could go after work. Also, too, the hospital where the physician we chose had privileges to deliver the baby was 45 minutes away. So when labor starts at 2 a.m., I'm now bundling up in a car to drive 45 minutes past 4 hospitals. I literally passed on the freeway 4 hospitals to get to the one where my physician had privileges. Why isn't there some universal credential? If you can deliver a baby at one hospital, you can deliver a baby at the hospital 20 minutes away. You know, it's kind of the same, in the same progress there. So I think, one, we need to make it more, I'm going to use a buzzword again, no silos. I hate when people say that too, but if you can have credentials to practice at a hospital in a certain city, then you pretty much should have it across the board. Now I don't know how it's going to work with insurances or who's going to be keen on the payer agreements and that kind of stuff, but from a patient standpoint and a consumer standpoint, it should be easy for me. I shouldn't have to be driving across town for that if my physician is going to deliver the baby anyway. So, but then you flip side that and you have the physicians, the nurses, they don't want to work second shift. They want to practice and round where they get the best reimbursement rate. I understand. So I think it's going to be, I don't want to say single payer because I'm not a firm believer in that. I do believe in competition in the market, and that across the board, people should be able to shop around and should be able to see transparent pricing. But I think some of the regulations we put on ourselves, like I said, when it comes to physician credentialing and such, or not reimbursing for a telehealth visit, I don't understand why if a doctor is going to take 20 minutes, we're doing this right now. And I think, don't get me wrong, I love in-person stuff, but I think people will gain knowledge and glean different aspects from our conversation. So if a physician can have the same conversation where he can prescribe you the medicine, again, in the appropriate circumstance, I'm not advocating for narcotics over the internet, but I mean, simple antibiotics and stuff, or insulin. If a diabetic needs insulin, they're going to need it for the rest of their life. Why do they have to keep going to the doctor for that? From a female standpoint, birth control. If a woman chooses to be on birth control, the idea she has to go to her doctors every 6 weeks to renew her birth control prescription. I don't get it. That's not patient convenient. But I also understand that the physician needs to get paid for prescribing that. They spent a lot of money to go to medical school.
Yeah, there are a lot of challenges in the system that we have to address. And one of them is that a lot of payment is still tied to people coming in for a physical appointment. And that we definitely need to fix that. That's another whole discussion, but you're right. And I'm glad that you referenced it. Next couple of years, what do the next couple of years look like at MLK Hospital?
So MLK, we are expanding our population health. That's our most aggressive effort. Anybody who hears MLK Hospital, the original MLK Trauma Center that was run by the county was shut down for substandard care in the 2000s. I don't work for that organization. I like to make sure I put that out there. It was replaced by the hospital I work for now, MLK Community Health. Now, we replaced a 540-bed trauma center with a 131-bed community hospital. So the population of South Los Angeles has not decreased in the last 15 years. So we have to focus our efforts out in the community. We're building a network of clinics focusing on outpatient ideas, medical office buildings, as well as expanding our population health team. Street medicine, one of our biggest consumers of emergency department healthcare is the homeless population. They come in the ED. Sometimes it's for a meal, sometimes because it's raining, sometimes because they have legitimate medical issues. Mental health co-diagnose you with a medical issue. So getting our street medicine team out there and treating these people where they're at, I don't want to say keeps them out of the hospital, but it keeps the smaller issues, the preventative care. A lot of the wound care stuff we see, they're festering wounds that have been like that for weeks, where if they had been treated, I don't want to say immediately, but in the first couple of days, it would have stemmed the problem right there, and we would not have had somebody with a 3 or 4 day inpatient stay. And from a financial standpoint, the individual who's coming in for a 3 or 4 day patient stay is not paying. So now commercial insurance has to make up that difference, where I get the payer side of it. But I think MLK the next few years, the huge focus will be getting out there and treating people where they're at, whether that is a homeless individual who's on the street, whether that is in-home care for somebody who regular individual who lives in a house and now doesn't need to go to the doctor, as well as expanding our telehealth. A network of clinics across South LA that folks can either walk to or take public transportation to is key. We have 3 open now. We have plans for more in the future. But the idea that anybody's going to take 4 buses in a 2-hour trip to get across town is not really their healthcare. Like you said, we're used to on demand. It needs to be convenient. We've partnered with some ride sharing companies. We turned our valet into a patient discharge transportation, which has been marvelous, instead of trying to chase down Ubers at 2 in the morning when someone gets released from the ED. And we just give them a ride home. The cost on it's minimal. I think the valet is $30 an hour or something. And the idea of what we're paying for Ubers or rides home, it pays for itself. And then you bring the patient back to their home. They're not out on the street. They're not trying to walk. They're not potentially incurring other issues. So I think that on-demand service is where MLK is going, as well as keeping the care in the community.
Wonderful. Well, I so appreciate this. Do you have any closing thoughts that you'd like to share with our audience?
No, really. I mean, I would tell anybody out there who is hunting for a professional in their organization, look outside healthcare. Just because someone's worked at 6 hospitals before doesn't mean they're a bad candidate, but doesn't mean they are the candidate. Look at folks who have non-healthcare experience for your non-clinical jobs. You'll find some amazing employees out there that you might have overlooked before. So I appreciate you having me. Thanks for the time today. And let's do this again sometime.
Let's absolutely do it. Thank you so much, Jonathan. This has been so enlightening. I've learned a lot, and I know our audience has. Have a wonderful day.
Thank you, you too.
Thank you. Same to our audience. This concludes the session. Thank you very much.